certainly something that is increasing in, women presenting a lot earlier because there is so much information now out there about menopause. We're all hearing all sorts of things. So I'm hoping that coming from the Australasian Menopause Society, that we can give you a really balanced opinion of where things lay at the moment. So if we move on to the next slide. This is just really my disclosures that are really that I do get paid an honorary fee for doing presentations, and I get supported to travel to meetings. Next slide, please. And whilst I've put this talk together, I do need to acknowledge that it comes from collective knowledge from the AMS board members, both past and present, all a really wonderful group of colleagues. And I've had a bit of design input from a colleague, Ruth Spencer, because I'm hopeless at PowerPoints. Can't be good at everything, can you? Okay, so this is where I always like to start, which is a group of friends of mine who have coined themselves as the Saturday morning dipping club. So these are a group of women who go down. They don't live in a tropical location, let me say. They go down and submerge themselves every Saturday morning into cold water. But this provides them with so many important opportunities. One, connecting with other women. It's really important to be able to connect with other women who are going through various similar experiences. They get to talk and share their experiences. Again, it's something we've not traditionally done, particularly in the space of menopause. It's been a bit of a taboo topic. And they're engaging in physical activities, which is outdoors. Not a load of vitamin D, but some vitamin D when you're living in the southern hemisphere, a little bit more in summertime. So it's a really important message that this time of perimenopause and menopause can be really lonely for a lot of people. So being able to share your discussions if you choose to, and also get the benefit of being outdoors with some physical activity is a great incentive. Dipping yourself under cold water, I'm not so sure. So next slide, please. So I guess it's important when we're thinking about menopause in the workplace that there are these kind of 3 M's where there can be some gendered bias particularly, but menstruation, maternity, and more recently menopause is coming into the limelight. And I think this is because menopause is a bit of a double whammy, because it's not only sort of this other stigmatizing time of life for a lot of women, but it's also when women are older, and we can find that there can be a lot of ageism around women in the workforce as well. So next slide, thanks. So I might just get you to click a few now, because it'll have a few things coming up. I'll tell you when to stop clicking. So one more and one more. There should be 2 more things. Great. So when we think about menopause and perimenopause, I think it is also very important now more than ever that we remember that this is a woman who's in a particular psychosocial context as well. So not everything is going to be related to menopause. And I think that is, again, really important when we're hearing a lot in the news now that, menopause is this really problematic time and hormones are going to fix everything. There is so much more going on for women. So we know women are dealing with increasing demands, often with elderly parents who they can be caring for, adult children living at home who well and truly should have perhaps moved out of home. Sometimes it's the demands of trying to care for grandchildren as well. And sometimes it might be that they've got a partner who's unwell, and they might have other chronic health conditions they're dealing with. So this can be a time of intense pressure for women. We know that women are less likely than their age-matched male peers to be engaging in physical activity. And we know that happens from early life with women. They drop out of sport a lot earlier than men. We know that women women over their 50s are the highest group of people facing homelessness. So there's a lot of financial insecurity for women at this time. Women in their midlife are the only demographic we're seeing an increase in consumption of alcohol, and it's not a surprise when you're looking at increasing demands, financial strains, less opportunity to get out and be active. Women in their midlife are at their highest risk of suicide out of any of the demographics over the course of their life. So we know that there are issues around depression, anxiety, perhaps isolation, again, financial strain, alcohol dependence that can be impacting on their mental health. And we also know that women are gaining weight in their midlife for a whole range of reasons. So there is a lot going on. Some that can be contributed to menopause, but not all of this. If we go on to the next slide, thanks, Jennifer. So that sounds really bad. I've painted a really negative picture of women in their midlife, but I think it is important to remember that this is a critical time in women's life where there is an opportunity to really look at how you can develop a positive path moving forward. Chronic disease is women by the age of 65 are 4 times as likely as men to have a chronic disease, significant enough to impact on things like just showering, so everyday activities. So chronic disease starts in our midlife and pathology builds up over time. So this is a perfect time to try and figure out, right, what am I going to do to set myself up for the healthiest life I can, not necessarily just the longest life, because a lot of us can argue that actually post-menopause can be the best years of our life for a whole range of reasons. Next slide, thanks. So what is it and what can we do about it? So if we go into the next slide, this next slide shows what's happening pre-menopause. So that's in a woman's reproductive life. And you can see this cyclical pattern of hormones. It's quite predictable for most people, quite regular. Women are often aware of those cyclical fluctuations. So sometimes mood can get a little bit worse before a period, feeling much better afterwards. Breast tenderness before a period, feeling much better afterwards. And you can see that sort of fluctuating course of hormones, which keeps things relatively stable or predictably stable. When we enter perimenopause, look at what the hormones are doing there. They are just all over the show from one day to the next. There is no rhyme nor reason as to what's going on, which is why we start to see a change in our bleeding patterns if we're still having periods, because some months we're ovulating with a high estrogen, some months we're not ovulating at all. So this is very reflective of how women are often feeling in this perimenopausal place all over the show with no predictability. And then we look at postmenopause where we see this flattening off of our estrogen and progesterone, an increased level of our follicle stimulating hormone, where things sort of come back to that even keel. That doesn't mean that's a particularly pleasant time for women, because they can have symptoms that are related to that declining level of estrogen. So if we go on to the next slide, thanks. So menopause is historically, I guess, been thought of as the last day of the last period. It happens really on one day. But now that women have IUDs, or they might have had an ablation of their uterus so they're not bleeding anymore, we're leaning more to think of it as the cessation of ovarian function. So it's where the ovaries are not operating anymore. For most women, it occurs between 45 and 55. It's considered early if it's between 40 and 45, but premature primary ovarian insufficiency under the age of 40. They're a very unique group, so we won't be doing much on them today. So we're really talking about the sort of regular kind of menopause. So next slide. And I've said, this is a reproductive transition. So it's also really important that we acknowledge that it's a neurological transition. So there's lots going on in our brain. It's a physical transition. Our risk of chronic disease or changes radically at this point in time. It's an emotional change. For some women, this is an incredible period of grief, particularly if they weren't able to have children and they might have really wanted to do that. Or it might mark this transition where they no longer feel like they're a woman anymore because their hormones change. It can be really liberating for lots of women as well, but it can be a sad time for some women. And it's cultural. It really does depend on what culture. I think in our Western culture, postmenopausal women are often seen as having done their duty, thrown on the scrap heap, no longer, having the joy and the oomph that we associate with younger women. In other cultures, women who are postmenopausal are really held in high esteem. And I guess we really want to work towards that, towards honouring the knowledge and skills, particularly in the workplace, that women in this phase have to offer to the community, to the workplace, to younger workers as well. Next slide, thanks. So perimenopause, as I said in that slide, it's the lead up to menopause. It's marked by change in bleeding patterns and periods if you're still having them. It's an easy guide to do it. Sorry, just back to that previous, back the other way for me. We're just going through the wrong way here. If we can revert back. Good, keep going, keep going, keep going. This one, great, thank you.
And sorry about that. I don't know what happened there.
It gets very touchy. So yeah, if you have an IUD or if you've had an ablation of your uterus where you're no longer bleeding, it's a little bit trickier to mark this period out, but we see symptoms of estrogen excess and deficiency. So times when we might have really sore boobs, really terrible mood, and times where we might feel incredibly flat. And then the sort of hot flushes can be in there as well. Can occur over years, and so it's variable for everyone. So next slide, thanks, Jennifer. And then postmenopause is really the 12 months after the last day of that last period, or if you haven't had periods, just back one. If you haven't had periods, then sometimes we might be looking at doing some blood markers to see if we can confirm menopause based on your symptoms. It lasts for the rest of your life. Women live for a third of their life now, often in this postmenopausal phase. It's where the FSH is persistently high, so that shows that the estrogen, the ovaries have stopped producing estrogen. And for most people, it's a natural process. It's part of life. It's what happens. Next slide, thanks. This just shows you all the tissues that estrogen and progesterone act on. So there's receptors on all these tissues throughout our body. So it's no wonder if we go into the next slide, we can see this huge array of symptoms that we have. So there are so many symptoms for so many women. If we go into the next slide, these are probably the ones that I would see more commonly, or that women would report more commonly. And these are the ones that we really may see a response to estrogen. Some of the others are anecdotal. We see women start on hormone therapy and we see that things do feel better for them, but we don't have particular data on the whole range of symptoms. So if we go into the next slide, I'm going to try and go through all these common symptoms and to tell you a bit about them and what we can do about them, which is really important. So the vasomotor symptoms are really common. Not everyone gets them, that they're very common. And I guess I should say here also that 20% of women will have very few symptoms going through menopause. 20% are going to have incredibly severe symptoms, and 60% are going to be somewhere in the middle there. So the hot flushes range in severity, and it can involve night sweats. So I had a woman this morning who's never had a hot flush but has terrible night sweats at night. So that's still considered a vasomotor symptom. We wonder if this is actually a marker for chronic disease. So if this is kind of the marker, and when we give hormones and see that symptom resolves, that might actually reduce risk of some chronic disease. So this is kind of still in that early phase. The good news is these are incredibly treatable. So if we go on to the next slide. We do know that hormone therapy is the most effective treatment for hot flushes, without a doubt. You can do all the lifestyle changes in the world that will help, but they will not treat. There are other medications if women can't or choose not to have hormones. So that's also really important that women know there are choices. There's some evidence for some complementary therapies, and I think I've got a slide later on that will highlight some of those, but they are very treatable. That is the take-home message. Next slide, thanks. So sleep disturbance, this is a very, very common presenting symptom. Sometimes that's due to the hot flushes. So hot flushes and night sweats are really disturbing your sleep. Blankets on, blankets off, fan on, fan off, pajamas on, pajamas off. Some women sweat so badly that the bedding is drenched and they have to get up and change everything. Some women are disturbed by nocturia, which is having to wake up and urinate overnight. And that's often one of the genitourinary symptoms that we see of menopause. Sometimes a sleep disturbance can be associated with anxiety or low mood, that you just can't sleep because you're so worried, or you've got thoughts stuck in your brain, you're ruminating, you're waking up thinking, I didn't do the job I wanted to do today, and you start sort of punishing yourself because you're not performing at your peak. But there can also be other primary sleep disorders like obstructive sleep apnea. So we have to keep these things in mind as well. If we move on to the next slide. And what can we do about sleep disturbance? Again, there's lots that we can do. Talking about sleep hygiene, really important. Talking about the MHT, again, that can be very effective if night sweats and hot flushes are part of it. Treating anxiety and depression can be incredibly important to improve sleep. And we know that sleep is so important for our brains and our bodies and our mood. And also we need to often think about, is there something here that we should be thinking about investigating, things like sleep apnea? Women who have sleep apnea post-menopause present again very differently to men. So we've got to get clued into what are the signs that we're seeing in women and think, do we have to look further? Next slide, thanks. The vulvovaginal symptoms, or we often call them the genitourinary symptoms of menopause, they are incredibly common and these persist. These, like while hot flushes and mood change and some of those other symptoms can just be through that transitional point or soon after menopause, they'll often get better for a lot of women. Not everyone, but most women, they will get better. The vulvovaginal symptoms don't. They often do need to be treated, and we need to ask people about these as doctors because women often don't want to share this information because it's still, there can be taboo, it can be embarrassing. So we need to ask. Those symptoms can be dryness, the feeling of itch, where often women will think they've got thrush and will be treating themselves for thrush, but it may not be thrush at all. The needing to go to the toilet more frequently, or having very painful intercourse as the vagina gets dry and there's less lubrication. So next slide, thanks. Again, these are incredibly treatable. One, we need to normalize that this is part of the change. This is part of what most people will experience so that women don't need to feel embarrassed. Skincare is really important. The vulva should only ever be washed with water or a soap-free alternative, but we have to be very careful. It is very delicate skin, particularly at this time. Vaginal estrogen works absolute wonders. There's also vaginal moisturizers, and there's a newer kit on the block now, which is a DHEA, so a sort of an androgen derivative hormone pessary that can be really helpful. That converts into estrogen and progesterone, and that can work really well. That's only just newly been released, so this is another option on the market, which is great. As I said, they tend to get worse if they're not treated, and survivors of breast cancer, because of the treatments they have, often experience this sort of symptom like it's on steroids. It can be a hell of a lot worse, and they can often feel very reluctant or find it very difficult to get help because the thought has been that hormones are totally out, vaginal hormones are totally out of the question. We're now starting to see that maybe there is a role for working with the oncologist or their treating team to see if we can try some vaginal estrogen to get relief, keeping in mind their symptoms are a lot worse. So next slide, thanks. Mood problems, again, are incredibly common. And when we think back to that slide that we looked at the beginning, which was from the Australian Institute of Health and Welfare about what else is going on for women in midlife, it's no wonder there's some mood problems. Tends to be increased if there has been issues in the past. So women who have had severe premenstrual dysphoric disorder or postnatal depression, or, you know, when they got their period, particularly moody. Anyone who's had this hormonally linked mood may get worse, but it can come out of the blue. It can be a first time, and we can see some anxiety, and lots of women will get the physical signs of anxiety, like, you know, heart palpitations, which can be partly associated with menopause as well. It's probably reasonable to do a trial of hormones. We don't have any hardcore evidence because the research hasn't been done. So sometimes trialing some hormones is reasonable, and then thinking about how else we can help women with mood problems is very important. And so that can be things like looking at psychological interventions or even some more targeted medications. But women should be given some options and some choices. Next slide, thanks. Brain fog. Now, this is one that's really common. Probably more than 50% of women experience this, and this can be particularly distressing in the workplace when you feel like you're just not able to perform at the level you were able to before. It can be difficulty concentrating, remembering things. Some women who will have been able to, you know, multitask, all of a sudden find they have to be very specific about what task they're doing at the time. And it can be really frightening. A lot of women can think this is the beginnings of a cognitive impairment or a dementia. Finding the right word, going to the fridge and not remembering what you've come in for, opening an email and thinking, oh, hell, where was I at with this particular project or topic? I just can't recall where I was at. Very normal. We need to reassure women that they will get through this. Most brains adapt really well. If we go into the next slide, actually, I'll have some tips there on how to manage brain fog. Reducing that mental load, owning it and acknowledging it, that this is a transitional period, you're going to get through it. When you've got a task, try and attend to that very actively and Don't allow people to distract you. It's all right to say, listen, I really need to be concentrating on this at the moment. Can you send me an email? Can we catch up later once I've completed this task? Use diaries, use reminders, use whatever you can. When you can't get the word out, describe it or think what it is, and trying not to be embarrassed. Just remember, this is happening. Menopause affects the brain. There's so many estrogen and progesterone receptors in that brain. And as I said, most brains do adapt to this lower estrogen status. So you can be reassured it will get better. But this does cause women to want to leave work or not go for promotion, or to step back or step down or go part-time because they're incredibly frightened and feel they're not performing. And one of the worst things you can do, I had one woman who said every time she couldn't quite remember something, they'd bring the 22-year-old girl from the front desk to help her. And she said it just felt very intimidating that, that always this younger person was brought in to perhaps remind her what to do. And she nearly gave up her job because she felt so anxious about that and felt that they thought she was useless. Okay, next slide. Now, for the women who aren't having symptoms, it is really important that they take on board that midlife is a really important time to have a good health check, because you become at higher risk of cardiovascular disease, stroke and dementia, osteoporosis, so weakening of our bones, and things like diabetes or developing a metabolic syndrome. So these are the health consequences of menopause, irrespective of whether you have symptoms or not. So keeping in mind, women in their midlife should always go and have a thorough health check. There is a health check item number available between the ages of 45 and 49. Unfortunately, it doesn't happen after that, but we're sort of working on that for women. But there is a health check, a Medicare funded health check that everyone's entitled to between the ages of 45 and 49. Very important for women that we address their risk factors and modify any risk factors they might have for these consequences of menopause, the things that happen once we lose our estrogen. Next slide, thanks. So how do we navigate midlife? If we go on to the next slide. These are some terrific books. So The Secrets of Women's Healthy Aging, that comes out of a study out of Melbourne Uni that followed women for 30 to 40 years, has some fantastic hot tips. It's a great read. Staying Alive was by a geriatrician who talks about how to achieve a happier, healthier and longer life. We know women live longer than men, but generally in poorer health. And this is a new one that's out called The Menopause Brain. So anyone who's having brain fog or wants to know more about it, this is a great book that goes into sort of the nitty-gritty of what's going on in the midlife and how to reduce your risk of something like a cognitive decline. So next slide. These are also on this next slide some excellent evidence-based resources. Jean House is fantastic for doctors and for the general population. The AMS, fantastic resources. Healthy Bones Australia or Know Your Bones, really good to talk about how to prevent yourself from getting osteoporosis. And the CogD Risk is a really great little risk reduction tool, evidence-based. It's online, very easy to do, takes 20 minutes. You can work your way through this. It will develop a really terrific report, which will give you a risk of developing dementia at age 65. If you have any risks, it talks through how to modify those, but it's also something you could take along to your GP to talk about if you wanted to. So some great resources there. Next slide, thanks. Now, it's really important if you yourself has menopausal symptoms, or one of your employees talks to you about their symptoms and they don't know how to find a GP. I always recommend, when you make an appointment with a GP clinic, your regular GP clinic, it may not be your GP who's best at it. Ask at the front desk, who sees the most women, who does the most women's health? Go and see that person, because you'll probably find someone who's got more knowledge and more skills and more confidence to help you through this time. If they say, look, we don't know, or doctors are the same, there's no sort of difference, and you're not feeling like you're getting anywhere or being heard, jump onto the AMS website where you can find a GP. You can locate a GP who's a member of the Australasian Menopause Society. It doesn't mean they'll be an expert, but they'll have an interest. So they'll know where to find out information. Remember, GPs have to look after a lot of conditions throughout, from birth to death, and none of us can be perfect at everything. So it is trying to find the best doctor, the best fit, the person who you feel most heard by. So next slide, thanks. When you book or when you're encouraging someone to book an appointment, it needs to be a long consult. Mine are booked for 30 minutes, but they always go for 45 minutes. I've got to change it because I'm always running late. It takes a long time, particularly if they're not a regular patient, because there's a lot of things you've got to think about. We need to take a detailed history. We need to know what the symptoms are, what their background is, what their family history, what's going on outside of these menopause symptoms. We usually use the AMS scorer, which I'll show you in a tick. This is not a diagnostic tool. It is purely a symptom scorer. It's just to assess where you're at. It's a subjective scoring. It's not objective, but really useful to see how many symptoms, how severe they are, and also great to see if we start treatment, is it working? Has that score come down? Are your symptoms better? Because you tend to forget. It's very hard when you recall back how bad you're feeling to say today, well, how much better are you? But this is a great tool for doing that. We often have to do some examinations depending on what are the symptoms or what we find, and we might need to do some investigation. So you may not walk into a consult and come out with treatment that day because there might be other things we need to think about. So if we go on to the next slide, this is the scorer sheet, which you can download off the AMS website. It's not a diagnostic tool, but you can just put through your symptoms. And if there's any other symptoms, write them down. Because often, again, if someone's focusing in on that and they're not your most significant symptoms and they don't ask, we may never get to what your most problematic symptom is. So just write them down and make sure you tell the GP what's going on. So next slide, thanks. And this is just, I guess, a template of a consult that I would do that just shows you the detail of what we need to know when we're doing an assessment at menopause. Very important that we don't forget about contraception. That always seems like, if someone came into us at 49 saying they wanted a baby, we'd say, you've got to be kidding. But at menopause, we have to always make sure that we remember women actually still can get pregnant at that time. So we need to make sure we've got that covered. But it is quite a detailed consult and a lot that we've got to cover. So often it might have to happen over a couple of consults. And that's really important as managers when you're talking to employees potentially about going to see a doctor, that they do feel comfortable that they are allowed to take the time to do that it's okay to take some time off to go and see doctors, and it might be more than one appointment. And of course, we can always give a medical certificate for that. So next slide, thanks. So when we're thinking about how to support someone through this time, it really is ideal if we can all be person-centered. So to look at the person in their social and cultural context, what it is that they're needing. It's going to be different for every woman because they're going to have different symptoms, different circumstances, different background. They may be on different medications. Lifestyle changes are really important. They can be some of the hardest things to address sometimes, and women, as we know, going back to that very early slide, are under a lot of pressure. So this is something often that we need to talk about gently and talk about over time. But we do know that for a lot of the symptoms, hormone or some of the non-hormonal treatments are going to be the most effective in dealing with many of the symptoms. So if we go on to the next slide, thanks. So these are the sort of things when we're talking about lifestyle factors that will make a difference. We know for women, the one thing that makes a difference for them to have a healthy life, as opposed to just a longer life, is exercise. It's finding something that they like doing and doing it every day, ideally for an hour. That can be walking, gardening. It can be housework as well, but we don't want to sort of spread that rumor around too much. But finding something that they enjoy and doing it every day, that will give them a much better chance of having a healthy life, irrespective of what's going on with menopause. Smoking, of course, can be a real trigger for hot flushes and terrible for our health. Calcium and vitamin D, important for our bones. Social activity and connectivity, really, really important for keeping people engaged, less lonely, lower risk of mood disorders, lower risk of suicide, lower risk of developing things like dementia. Alcohol, there's probably no safe level of alcohol, to be honest, but we do advise no more than 2 standard drinks a day, although that's sort of changing now to 1 standard drink for women and also having some alcohol-free days. Alcohol is a shocking thing for sleep and for hot flushes as well. Eating a Mediterranean diet is probably the best evidence for, and we know how important sleep is for pretty much everything, and sleep can be so disturbed at this time. So they're really important things to be thinking about. Next slide, thanks. So this is just a link to the information sheet that we have, which talks about the evidence behind all the various lifestyle changes. So I'd suggest everyone who's going through menopause have a look. As managers, this is a good place to signpost people to have a look at what the latest evidence is. We update these fact sheets at least within every 5 years, or when there's been some new research come out, we try to get these updated as quickly as possible. Next slide, thanks. So more menopause hormone therapy. When we're treating people for menopause, we call it menopause hormone therapy. When we're treating people under the age of 40, we call it hormone replacement therapy, because that is replacing hormones for someone who should ordinarily have hormones. Post-menopause, of course, it's normal that we don't have these hormones. That's why it's called more menopause hormone therapy, not replacement therapy. It is the most effective treatment available. If started in the time of perimenopause or in the first 5 years of menopause, it's extremely safe for the vast majority of women, not all women. In this age group, so when we start it close to the time of menopause, it does reduce the risk of cardiovascular disease. We can't prescribe it for that, but it does do that. It reduces the risk of osteoporosis. We can use it for osteoporosis. There is a PBS indication, so it's funded for osteoporosis. Which will prevent the fractures, and it can also reduce the risk of diabetes. Again, we can't use it for that as a primary prevention, but it's useful to know that. We don't know if it prevents dementia at this stage. We don't have the data on that. We do know if someone is under the age of, has primary ovarian insufficiency or has had a early surgical menopause, we know it does prevent their risk of getting dementia, but we don't have the data for the woman who goes through menopause at a regular age. So next slide, thanks. And this is really important, very important take-home message. If you are thinking of menopause hormone therapy, I want you to pay attention. If you have a uterus, we have to give you a progestin. So we give you estrogen to treat the symptoms. That's going to treat the hot flushes or the insomnia or the genitourinary symptoms or the mood change. The progestin that we give you is really important to protect your uterus. We don't give that so much to treat symptoms, it's to protect your uterus. So estrogen's like blood and bone to the uterus, to what it is to a lawn. It will make it very thick and lush. A very thick and lush lining of a uterus can cause cancer. So if you ever are prescribed this, remember the progesterone is really important for your uterus. We give you that either in a cyclical combination or a continuous. So that means you'll get estrogen every day. If you're perimenopausal, we'll give it to you cyclically. So it'll be like the pill. You'll have some days where it's estrogen and progesterone and some days when it's not, so that then you can have a scheduled bleed in that time. But if you've postmenopausal, we would give you the same dose of estrogen and progesterone every day. If you don't have a uterus, it's very easy. We just need to give you estrogen unless you've had severe endometriosis, which means we might need to throw in some progesterone as well. So very important take-home message. Progesterone is very important for women who have a uterus. Next slide, thanks. We're hearing a lot about testosterone. I don't know if you're hearing a lot, but I'm certainly hearing a lot and having a lot of women come in asking for testosterone as the missing hormone. We don't know really a lot about testosterone yet. We know it's indicated for women who are really distressed by a low libido, no longer getting any pleasure from sex. That's where it may have a role. Most women don't. It doesn't do a whole lot for, but some women it is great. But it's certainly at this stage, I don't want people thinking this is the missing link, and if you have some testosterone, you'll feel great. We don't have that evidence. We're working towards figuring that out, but it's not there yet. Doesn't mean you can't have the conversation, but just try and block out of your head that this is the wonder drug that everyone's talking about. Okay, next slide, thanks. So what are the benefits and risks? It's really important. So this is a slide which is anything on the right side is showing a benefit, anything on the left is a risk. So if we just look at the top one, we could just concentrate on hot flushes and vaginal atrophy or those genitourinary symptoms. You can see that for estrogen only, which is the black box, or the white is estrogen plus progesterone, those symptoms are so much better. If we go into the next slide, that highlights that bottom bit of that slide, so the B part of the slide. So again, anything on the right shows an absolute benefit. Anything on the left is showing some risk. So if we look at breast cancer, we can see in the estrogen and progesterone group that there is a slightly increased risk of breast cancer. There is an increased risk of blood clots if we go down low. There's a slightly increased risk of stroke, and there is a slightly or bigger increased risk of cholecystitis, which is gallbladders, gallstones. So these are things when we're talking to women that we need to take into account. We need to measure their baseline risk and we need to adjust treatment around that. But by and large, these risks are very low for most women and the benefits are absolutely very much documented. So next slide, thanks. Women really worry about breast cancer. All women have a 1 in 7 lifetime risk of developing breast cancer. Family history of breast cancer, whilst it can increase your risk depending on how many people, at what age and what type, but it's not considered 100% contraindication for hormone therapy. A lot of women think because they had a grandmother with a breast cancer, there's no way they can have it. That's not the case. The magnitude of increased risk of developing a breast cancer on hormone therapy is incredibly low. For the first 5 years, it's probably negligible. In fact, if you're on estrogen only, we think there's a reduced risk, but on both, it's a very negligible risk. After 5 years, that risk does increase a little bit. But if we look down along this little infographic, which comes from the British Medical Society, really having a BMI that's greater than 30 puts you at incredible risk of breast cancer, way over the use of MHT. It's equivalent after 5 years of use. The risk is equivalent of having 2 glasses of wine a night. So alcohol probably causes the same number of increased cases of breast cancer as HRT does after 5 years. So it's a very low risk. But we need to have those discussions so women can make an informed decision about treatment. Next slide, thanks. But what are the common side effects? We've sort of talked about those as serious ones. So you can often get a change in bleeding or some spotting. And that's why we start women who are perimenopausal on that cyclical regime, so at least it's predictable. Breast tenderness, very common. So we have lots of estrogen and progesterone receptors on our breasts, so we can feel quite tender and we can get some bloating and some fluid retention. These are usually managed really well by starting on lower doses and just titrating slowly. So most of these do settle down for women, but it's really important women know about this because if they go home and they start taking it and the first thing they get is these terrible tender breasts, of course they're going to think, oh my God, am I getting breast cancer? Or this is really bad for me because my breasts are so sore. It is very common and mostly resolves. So next slide. So what are the non-hormonal treatments? What's available? Well, there's not a lot of evidence for a lot of the herbal preparations that you can buy at the chemist or the Nature's Works kind of shops, those kind of things, and some may have some safety issues. There is some evidence for things like cognitive behavioral therapy or hypnosis, a little bit less for yoga and vitamin E, particularly when we're talking hot flushes, but there are other prescription medications for women who can't have hormone therapy, for example, if they've had a prior breast cancer. So whilst we might be able to use vaginal estrogen on these women with a previous breast cancer in consultation with their treating team, we would never be using oral. Well, I'm not going to say never because there are always exceptions, but we would be very reluctant to use systemic hormone therapy on these women. Next slide, thanks. So this is the infographic on the website, which does go through some of those complementary therapies. So if you're thinking of what's out there and you don't think you want to do MHT, but you might want to try something more natural, I would encourage you to jump on this website and have a look and use that traffic lights system in terms of the things that there is now some evidence for or where there could be harm. So next slide, thanks. And then the other prescription medications we can use for hot flushes, some of the antidepressants work particularly well for women. Of course, these can sometimes cause hot flushes as well. So you have to be careful in which ones we use and which doses. Gabapentin is a very old-fashioned anti-epileptic or medication that we use for neuropathic pain, so nerve-related pain, but it can be quite effective as well. Clonidine is something that was used a long time ago for blood pressure. We don't tend to use it so much anymore, and we're using it less for hormone therapy because we're seeing benefits of other medications over clonidine, and it can have some side effects. But newly on the block is this medication called fezolinetant. There's been a lot of media about this as well. It works on a receptor in the brain, very effective at reducing hot flushes, and a great option for people who don't want to take hormones. We don't have the data yet for women who have had breast cancer, but for the other women, it seems like a really, really good, viable option. Next slide, thanks. So, menopause is inevitable. If you don't get beyond menopause, something awful has happened to you. You haven't had the privilege of getting old. So it is what's going to happen. Everyone's experience is very unique. And when we're thinking about workplace there, we've got to remember that you've got an individual woman in an individual workplace. So it's very hard to have a one size fits all in a workplace. I think that's where open discussion, acknowledgement of that it is happening, acknowledgement that there's a large percentage of women now in the workforce are in that age bracket. We're seeing women stay in the workforce longer and longer now. So it is something that does need to be addressed, because the women of this age group are a absolute asset to a company. They've got loads of years experience, loads of life experience, lots of potential yet to reach often. So we want to be able to keep them in the workforce. Leaving the workforce for menopause symptoms, which can happen, can really put women on the back foot. Not only financially, it can put them on the back foot emotionally. They can become socially isolated. These are all the things that can put them at increased risk of chronic disease. So it is a significant transition point, full of challenges from lots of different angles. Being a midlife woman myself, I know those challenges. It's not all bad, but it can be very messy for some. Hormone therapy is effective and safe for most people, but it's not a one size fits all. There are issues, as we know, with accessing medications. We're working very hard to ensure that this is addressed as an issue, and also that we get more of the medications on the PBS so that they'll be funded, so that every woman will have the option of all the medications to choose from, and that there are non-hormonal alternatives as well. So if you can't or don't want hormones for whatever reason, there are alternatives out there. You do not have to suffer the symptoms of menopause. There's help. Next slide. Thanks, Jenny. Oh, and that's it. Last slide. So thank you for listening for me. It's really great to be able to have the opportunity to talk to people about some of the, I guess, the evidence around menopause, what's out there to help, and also thank you from the Saturday morning dipping club, who are all in their perimenopausal, menopausal phase, and who have been very generous to allow me to use their photo, but also very passionate that other women can get out and get the help that they need, and that workplaces also, I guess, can understand what their role is. And we do know, interestingly, that women who feel they have supportive line managers who they can talk to if they want to actually score lower when they do those symptom scorers. So I think that's pretty impressive, and it says a lot for what a supportive workplace can do for women as they're transitioning through this phase. So thanks. And if there are any questions, if I've got time for questions, I'm not sure how we went for time there.
We went beautifully for time. Are there any questions at all from the group?
And as I said, I'm very happy, if you want to email questions in, because you don't want to ask in front of a whole group.
Ellen has a question.
Great.
Hi, Ellen.
Hello. I'm just wondering, like, if you're on the contraceptive pill, does that sort of shield you from working out whether you're going into perimenopause or menopause?
It does, in the sense that it's controlling your reproductive cycle. So you're still going to be having that regular bleed every month. So you're not going to see the changes that you see for someone who's not on the contraceptive pill. And I mean, the contraceptive pill we know is incredibly safe for women up to the age of 50. But once you hit 50, the risks outweigh the benefits, and we then need to think about coming off the pill and then seeing what happens.
Thank you. Right in that demographic of like having to think about this, and like, how will I know?
Yeah,
Thanks. That was very
Once you come off it, you'll know pretty soon.
Okay, cool.
Thanks, Ellen. Mishka, you had your hand up there. Did you have a question as well?
Yeah, and not so much a question. Just wanted to say thank you that this was so insightful. It's not something that I think is regularly spoken about, and I'm probably in a demographic where it's absolutely not spoken about yet. But it's so useful to kind of, I guess, put that on the horizon and actually know about it, rather than, I imagine it's quite scary for a lot of women who get there and don't have these insights.
Yeah.
Thanks,
It is. I
Mishka.
mean, when I grew up, all I knew about menopause was it meant I wouldn't have my period anymore, which of course you go, hallelujah, isn't that great? But you don't have had zero knowledge of what was going to happen, zero education really in medical school, a little bit in general practice training, but honestly, not a lot. And it's an area that I've certainly had to upskill because, as you said, women aren't forewarned, so they come in just going, "What the hell is happening?"
Bronwyn?
Thanks, Marita. This has been amazing because I seriously did think I was going into dementia at one
Yeah,
stage in the last couple of years, and it was frightening. Um,
yeah,
and I have taken a few key phrases and I will send them to my staff and my peers every now and then,
yeah.
particularly around the brain fog. I really resonated with how it can give your confidence a bit of a
Oh,
kick as well.
yeah.
So this has been amazing. Thank you so much. The other question that I had was, you had a list of GPs, etc., that had knowledge in this area
Mm.
in Victoria. I'm
Mm.
based in New South Wales. Do you have
Oh,
any?
it's Australia wide. So if you jump onto the
Oh,
website,
yes.
it's based across all the states.
Oh,
Yeah.
perfect. That's
And the other
amazing.
thing that's really important to know now, women won't know this, I don't reckon, that Medicare recently introduced a permanent telehealth phone number now for anything that's sexual and reproductive health related. So that means if you couldn't find a doctor locally, but you found a doctor in a different state and you thought, I really like the sound of that person, or this looks like for a good fit, whatever. Because once you find the doctor, you can do a little bit of a Google search if you want to. You're actually entitled for a Medicare rebate now. So when you book an appointment remotely, some of the reception staff may not be all over this, but you can say, actually, because I say, oh no, you haven't seen our doctors before, so you can't do it. You actually can see someone remotely and get a Medicare rebate for it. It's a little bit tricky because if you need to do an examination, for example, it can be a little bit harder. But for women who live remotely, it's an amazing opportunity if you can't find someone locally. So that's really important to know. And also, Bronwyn, I was going to say, and for everyone listening, I'm a co-host of a podcast called Dementia in Practice, and our last episode of our last season, which was season 3, or our most recent season, I interview Caroline Gurvich, who's a terrific neuropsychologist who's done a lot of work on the brain and cognition. So I'm interviewing her, and it's a really useful little episode on brain fog and how that impacts on women and what you can do and what it means and what we know and what we don't know. So that if anyone is thinking that they're experiencing that as a symptom, jump on and have a listen to it because it is quite reassuring.
Yeah, that's great. What was that name of the
So it's
podcast?
Dementia in Practice is the
Okay,
podcast,
great.
and it was just season 3, episode 7.
Thank you so much. This has been great.
Thanks,
Excellent.
Bronwyn. I think, Priscilla, you might have had your hand up. We've probably got time for one more question.
Oh, hi, thanks. Yeah, I guess just on the back of Bronwyn's comments and Mishka's, and I'm sure everyone's, this has been amazing, particularly for those of us who are the cohort who are affected by this at this point in time. And also just on the back of Bron's words, the brain fog for me has been terrifying. And I, have just had a recent diagnosis that means I'm no longer able to have any MHT. So I think I will be listening now to that episode to try and get some tools and things to try and assist with the brain fog. And just to anyone out there, if I'm sounding a bit off on a day, please just have a bit of compassion for me because that's where I'm at.
Yeah, and
But
it's
thank
really
you so much for your
hard.
time. Yeah.
I reflect back on, I had some difficulties in a workplace, probably 3 years ago now. And yeah, I was like, I couldn't understand why I just couldn't keep up with the younger women as well. I was like, how do they remember that? And I don't remember that. Maybe I wasn't at that meeting. I'd look back, I was at that meeting. Like, how have I not been able to remember that? And it was really, really frightening. I had a dad with dementia. I was like, oh my God, I'm going to get it like dad did. But of course, women in our age, it is incredibly rare to develop dementia. So, but you think that's where you're heading. And to have gone through that and also learned how to manage, with lists and with diaries, and just having to say to myself, look, I have to do this, otherwise I'll forget. Um, it really is life changing, but it is incredibly scary. And I've had women who have been placed on, work performance programs because they haven't been quite meeting their target, and a lot of it has been around brain fog and just with people having no idea. And these are incredibly competent women. I've even had some women at home actually who aren't in the workforce who have been rubbished by their kids or their partner for, oh, what did you say that for? Or, why can't you remember anything? Oh, God, Mum, you're always saying, what did I come in here for? Like, which can be incredibly demoralizing. And so for them to know this is part of this transition, and probably because you're looking after everyone else, also not looking after yourself as well. So it is a really, one of those issues that is really important to address. And for most women, it gets better.
Yeah, thank you. It's so 100% true. And I think also you find yourself, and I've heard it said somewhere before, and I'm not going to be able to repeat it correctly or accurately, but it's some kind of sandwich that you're in at this stage where you're looking after children as well as aging parents, and then you're going through this, and your plate is just so full, plus trying to manage a career and everything else. It's a very intense time. So yeah, be kind to yourselves, ladies.
Yes.
And thank you again.
No worries. Thanks,
Priscilla.
for
I think that's called the wedge generation, and I'm right in there with you at the same time. That's what I call it anyway. Well, thank you, Marita, for such an informative session. I think it's very clear that we've all taken away a lot of valuable knowledge, and we very much appreciate your time and expertise. Great. Obviously, for everyone on the call, this is a really important topic for everyone to be aware of, not just women. We've all got mothers, sisters, daughters, female colleagues, friends. So this is far from being a women's issue in isolation. And if we can remove some of the stigma and get the conversation going, I think we'll be able to support a lot more women in the workforce. As Marita explained, that wide age bracket is right at the top of, someone's career. It's really important for us to all be aware of the challenges that we're facing during that time, so we can identify opportunities to support those people in that time. Please pop over to the Australasian Menopause Society website. It's a great website. It's very easy to use. There's a lot of content on there. There's also options to view content in other languages. So thank you again, Marita, and thank you to Janice for organising today's event. Thank you for all your attendance and your engagement, and I hope you all have a great day.
Thanks.
Thanks so much, everybody.
Thanks, everyone.
Thank you.
Thanks.